raise your hand if you're familiar with this form. Pink form. Okay, sorry. Raise your hand if you're not familiar with the form. All right, so there are some of you. Okay, so this is a simplified advance directive, is how I try to explain it. One of our geriatric attendings, Dr. Steve Lai, the hospital received a grant to go out to the 10 nearest nursing homes, this was a few years ago, educate them on advance directives, get these specific forms filled out. They educated all the paramedics as well, and then our emergency room staff. The idea is that we need continuity care of end-of-life wishes for our nursing home patients. So it's supposed to be filled out by a physician. It can be filled out in the hospital or in the nursing home. It comes with the patient. A copy of it or physically comes with the patient. It stays with the patient. It goes back to the nursing home, the same form every single time. So we have started to see these more often. It is now a state, it's available throughout the state. It was just available to certain counties at first, but it is a very good thing. There are some other revisions that are being made with it, but it spells out in simplistic terms what end-of-life treatments that this patient may or may not want, the family contact information, and that's it. So please become familiar with this. This is something that should start really like in the clinics, even the clinics. If you're dealing with end-of-life care in your clinics, liver failure, cardiac failure, CHF, renal failure, this type of form should be a major education point in your clinics. So also out in the community, volunteer spiritual care providers, our chaplains are training volunteers to be a listening presence to our families so that we have 24/7 coverage of that. That's the idea. They're working on our hospital remembrance service. We have volunteer hospice liaisons at the moment. They started in July. They have a desk in the express care unit, and their role is so that the emergency room can have a resource for a patient maybe that's coming in that really could benefit from going straight back home into hospice instead of being admitted to the hospital and going through all of what we need to do before they get to hospice. They may end up dying in the next couple days in the hospital rather than dying at home. So ideally, that was going to be what our hospice liaisons would help the emergency room. They also are available for education to anybody. If a physician is wondering, could this patient benefit from hospice care? They're there. They come right up to the family and the physician, talk to them. They're working very closely with the case managers and all their referrals. They're available Monday through Friday, 9 A to 5 P, and their hospital, their beeper number is with the hospital operator. So, as we summarize, as we're coming to the end here, what would be the ideal palliative care team? Right now, we've got an awesome start. We have 2 awesome physicians that are heading our palliative care team. We have a resident that's working with them. We have social workers on every unit that are there to support end-of-life decisions or education. It would be nice if we had a specific social worker that could work with end-of-life issues. Some of our social workers are very comfortable with it, some of them are not. Having a full-time chaplain work with our end-of-life, with our palliative care committee. Right now, we'll absolutely take what we have. We love our chaplains, but it'd be nice to have more coverage on the weekends and in the evenings. They have been active committee members on the palliative care committee, and they also, in helping us staff emotionally, was it 6 months ago? Are we doing this every 6 months, the Healing Hands? Once a year, okay. So they're going to do another Healing Hands blessing in a month where they go throughout the whole hospital, try to hit every single unit, and with us, we hold out our hands and they do a very simple blessing of our healing hands, which affect the whole hospital. So it's just support for staff to help us realize the impact that we're making with our patients. So what we are missing, though, in our palliative care team is a nurse. We have our palliative care committee. We've got various nurses trying to make a difference in our different units in different ways. But this has not yet been worked into the budget. All other hospitals in our state with palliative care teams do have a nurse hired into their team, either a nurse practitioner leading the team or on the team. What would be the benefits of having a nurse on the team? Much earlier referrals initiated through nursing, nurse to nurse, and then on to the palliative care service. Implementation of all the palliative care committee work that we're doing. This is a very grassroots type of committee. Bedside nurses are coming, we're talking about it, what can we do about it? Let's try this. But we don't have a lot of support from the top. We have, Victoria has come once in a while to our committee meetings, but that's not her sole job, is to do palliative care education. She's got many, many hats. As well as most of our nurse managers. They have many, many hats. So to have one nurse dedicated to palliative care would really benefit the whole hospital. The role would be making rounds on the units to listen to physician and bedside RN end-of-life issues, similar to what the resource nurses already do now. Many of the cases that the resource nurses try to handle have to do with end-of-life issues. Many of the RRTs we come to have to do with end-of-life issues that could really facilitate a nurse and a palliative care team really in collaboration with the primary team. Making first contact with families with simple assessments and family understanding of goals of care. The nurse could then make recommendations to the physician for an official palliative care referral with follow-up on code status discussions or symptom management. The education of all staff to LNEP principles and providing emotional support to all patients, family, and staff regarding end-of-life issues. I have not brought up debriefings. Dealing with death is hard. It's really hard. And especially in full code deaths, when our patient has died suddenly, the physician and the nurse are left wondering, did we do something wrong? There's a lot of guilt associated with that. So debriefings are really important. When we have sentinel events, when we have big things that happens, we get our debriefings. But there's smaller debriefings that need to go on throughout the whole hospital most of the time. So that is the ideal team. We've got a great start. We're moving and shaking with our palliative care commitment right now. What can you do as nurses at the bedside as we stand now? Master pain management. A part of the palliative, the pain and symptom management order set on the last page is an awesome, I didn't include it though, I should have, page of a summary of narcotics, best usage, and effects. Knowing that, memorizing it, if you've been around, you kind of know it already. But master pain management as well as symptom management at the end of life. Tachypnea, that patient breathing fast, our morphine drip, whatever other medications we need to use to make that patient comfortable in their final hours, we need to master that. Learning the cultural end of life needs of our patients, being the patient's advocate, asking questions. Don't just assume that the physician, RN, and the family are on the same page. Collaborate with the team and family to establish clear end-of-life goals focused on patient wishes, dignity, and comfort. In the end, it's not all going to go the way you want it to go. The family may not ever accept their loved one is dying. So I like to keep this at the back of my mind, the serenity prayer. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. That's it. Any questions?